Good morning, everyone. My name's Kristen. I'm a chaplain resident at Aurora St. Luke's, and I'm going to be the moderator today. I have the great privilege of introducing to you Mel Tepley. She comes to us from Omaha, Nebraska. We're so grateful that she's here today. She's over at UNMC, working in outpatient palliative care, and has additional skills as an educator and a parent. We're very glad to have her with us today. Mel?
Thank you. This is a little bit more intimidating talking to a palliative medicine crowd. I'm used to talking to people where this is all kind of fresh for them. So this has all been information that's been deeper in terms of me helping to understand what my patients and families are going through. And that's been very practice changing for me over this past year. So I hope you all find some new pearls in here. So I have about 20 minutes of content, and then I want to open it up for discussion. And my basic layout is talking about, what we think about for emotions in the setting of palliative medicine, going really to do a deeper dive into that emotional experience for patients and families, and then how I would hypothesize we can expand how we respond to emotions for our patients and families. So we know emotions are important, right? It pops up in all of our major frameworks for how we have conversations around serious illness. And we also know that the emotions run highest when we're talking about prognosis. And we have a lot of good data that patients and families want to know about prognosis. And I work in the outpatient setting, so the hospital is always saying, well, we need to have these conversations earlier. And I will definitely attest to, anecdotally, it doesn't seem like the numbers fit this graphic of everybody wanting to talk very openly about their prognosis, that there is some guarding and some difficulty in terms of trying to open up these conversations, especially earlier in the illness course. So you all know this very well, that we process emotions in two ways, right? It's the cognitive and the emotional. And I would argue that there's a very strong, complicated mixture of the two. I would go so far as to say, I think it's rare that we ever make a truly rational decision. When we're talking about that emotional experience, I want to highlight that this happens for the patients and the families at the same time that it does for us as providers. I very specifically still remember going into the rooms the first time as an attending on my own and feeling these same emotions from a different perspective while my patients were feeling them too. And I think that's important for us to acknowledge when we're facing these conversations. So there's three components to an emotion. One, we may not even recognize. Oftentimes, I think we think about that after the fact as we're trying to give language to it. But so that subjective experience will happen, and then we go into that fight or flight response, right? And that brings that physiological response that makes it difficult to stay present with what's going on in our surroundings. And then we have our behavioral response. I'm going to reference this book, Crucial Conversations, that's sort of a leadership book that's been wonderful for me, both in the workplace setting and in my personal life. And I love this response that they talk about in Crucial Conversations, which is if people are in a highly emotional state, if they go into extremes, they go to silence or violence. And so obviously we don't have patients for the most part that are going to physical violence, but they'll go into anger or that silence, they'll go into shock. I like to try to put things into buckets, although obviously this is on a spectrum and obviously people will shift with where they are over time. But I find that people are kind of in these three categories of coping. And so I differentiate this a little bit from the Kubler-Ross stages of grief, that you've got our folks who are ready to discuss things, right? They say, it is what it is. Tell me what I need to plan for. We say they get it. You've got folks that are in the middle, where I would say sometimes they go into silence, where it's hard for us to figure out what they're thinking. And it's hard for me to tease out what exactly is going on in their mind. When I'm able to tease out a little bit more, they'll kind of go into why me, or kind of thinking about, well, if I just done this, or if this doctor had found this, still kind of in that bargaining. And then you've got the folks that I think are the most difficult for us to support, where they're in that violence. And I would categorize that as either that resistance, the anger, and also that unrealistic optimism, where they're just, I only want to talk about the positive. And I really try to avoid the word denial. It's rare that I meet someone who truly does not understand what's going on. A part of them somewhere in their brain acknowledges that, but they have so many different barriers that they are putting on to try to avoid that emotion. And it's not just that one person, it's the entire family, and they may be in different processes of how they're coping and dealing with things. And then on top of that, it's not just that family. We also bring emotions in what patients and families trigger for us, and then also what other providers on the various different teams are thinking and how we respond to them. And so that's really important for us to acknowledge that before we're walking into those rooms with patients and families. So this is the book that I was referencing, and I just love the way that they give a little bit of a different perspective, and they really boil things down into things that are very digestible to wrap my head around what's going on here. So they talk about crucial conversations having high stakes. So for us, we're talking about life and death. They talk about opposing opinions. So I would argue that patients will have opposing opinions in themselves. They'll swing back and forth between how they're thinking through something. Then certainly the family will have differing opinions. And then us as the medical providers will have differing opinions. And so of course, emotions are going to run high. I love how they talk about how we handle crucial conversations. We can avoid them, which I have done. We can face them and handle them poorly, which I have done. And we can face them and handle them well. And I think that all of us agree that when we do that well, it is really rewarding and gratifying. And in terms of why those conversations don't go well, I think there's a couple things that I hadn't really thought of before that some of these are obvious, but the emotions tend to rule. We know that. Our bodies will physically react. And a lot of the work that I've been doing with our group here is talking about how if we can have calm bodies, that actually makes the conversation go well. So our tone of voice, our pacing of language, our body language, us being aware of that is just as important as what we are saying. And that, we're under pressure, I think, as the palliative medicine team. People are expecting us to get the DNR or get them to hospice. And we know that that's not always the reality. And then there's times when we're stumped, where I have patients where I just say, I don't know how to reach this person emotionally. These are all given to you, but just to say, we actually have data that emotions affect how we process information. So when I work in the oncology clinic, so when the oncologist says, oh yeah, I've told them the prognosis very clearly, and then it's not that the patient didn't hear it, but their emotions were overclouding it. So it was hard for them to pay attention and to really retain that information. So talking a little bit more into a deeper dive of what patients and families are going through. So my family, we talk about death a fair amount, and we talk about what would be in some ways an ideal death. And I think most people tend to agree that they would like to die at home. They would like to die free from pain. They would love it if they could just go in their sleep, because then it wouldn't be a burden to their family. And I certainly know some people who have had that experience, although we know in reality, most people don't. They have to go through that dying process. So my family calls that kind of like in your sleep going the golden ticket. Hopefully it's later in life, not early. But as I said, most people don't get that golden ticket. They have to go through all the different stages of what it means to have a serious illness. When I think of the emotions that I tend to see and explore, I really like this analogy of an iceberg. I think there's some overt emotions that we see, but then more covert experiences that I would argue it's our job to try to tease that out for patients and families. And so anxiety and anger and shock, those are pretty easy to see. That frustration and fear and being overwhelmed, I think that that's something that we are especially equipped to start teasing that out for families. Over time, what I've started to recognize is just how much shame people have around expressing their emotions and worry about how they'll be perceived if they do that. And then a lot of the work that I've been getting into more recently is prior trauma And grief, I would argue, is at the heart of everything that we do, and not necessarily in the way that I thought about it before fellowship. So the two underlying processes that I tend to see are fear and anxiety about the uncertain future, and grief about all the losses that happen along the way. So the chaplain in my fellowship, I love this saying that he had, which is every change is a loss and every loss must be grieved. So at the same time that our patients are having the physical experience of this serious illness, there's also an emotional course that goes along with that. I would argue that if people are not able to appropriately grieve the losses along that emotional course, that they're going to be stuck and they're not going to be able to get to a place where they can accept their death. And so I have some people who are on their deathbed and still figuring out why this diagnosis came to be. So they're stuck all the way up here when their disease course has taken them all the way down here. So at the time of diagnosis, it's that uncertainty about the future, that loss of expected future. I'm not going to see my kids grow up. I retired 2 months ago and we were going to travel the world, and now that's not going to happen anymore. Once people start telling family and friends, they're no longer treated normal. So the most treasured relationships they've had in their lives have changed. When people start disease-directed treatments, it's, they don't know how they're going to feel. Their appointments, they may have complications, and so they have to come back for various different things. And so there's just no way to plan day to day, even trying to do a lunch with friends. They're like, I don't know how I'm going to feel, so I can't commit. As people start to have further progression of their disease, they may look different, they may feel different. Further on in the disease stages, they can't do the things that they used to do, which I find to be the biggest thing that I talk through in terms of grief for patients. And then when people are finally in that terminal stage, if they haven't been thinking about it before, having that fear of the dying process, but also just that fear of being dead, that FOMO of missing out on the wonderful things of life. So I know that in the Friday Chalk Talk, we've talked a little bit about this battle language, particularly in cancer. And so I wanted to highlight things that have come to awareness for me about this. And I'm going to use oncology as the example because that's where we see all of these images. So when someone gets diagnosed, particularly with a metastatic cancer, but any cancer, they'll say, I'm going to beat this. I need to stay strong for my family, right? And the internal narrative is, I have to keep things as normal and comfortable as possible, which I just showed you is impossible to do when they're facing a cancer. And I don't want to upset them, and I don't want them to treat me differently. And again, that's something that they can't control. I found this poem online, and I'm not going to read through it in the interest of time, but I want to highlight that when we talk about strength, I think strength is really important. And I think that we kind of confound this with a couple other things. And so I want to try to dispel this myth that the focus should only be on strength, because I think there's more to it. So if we're talking about the pure dictionary definition of strength, it's a good thing. I think the difficulty is that because we as humans want to put everything into binary terms, that if people don't feel they're meeting that expectation of strength, particularly it being physical strength, that then they're weak, and weakness is bad. And if we're looking at the pure semantics of it, weakness isn't really a thing. I would argue weakness doesn't exactly exist. People can be physically weak, but if we're talking about emotional strength and emotional weakness, I think that's the more careful language to try to explore with patients and families. So the narrative that we as a society have built up is that courage is kind of confounded with being physically and mentally strong, and fear and vulnerability, therefore, is weakness. And so that's right. I really think that is where the damage is, that it has to be this mutually exclusive thing about being strong and courageous and not having fear. So if we're talking about fear and vulnerability, and I'm looking at those definitions, the way I see that, those are just the facts. We all know that we're mortal. We all know that we have the ability to be harmed. And so those are facts of life that we have to face. And so the question is if we face them or not. And so that's where courage comes in. And I want to point out that courage requires strength, like strength is inherent to having courage. And so if we're taking this kind of more expanded look at it and really trying to be precise in our language, I would argue that when people are having an emotional response, this is the process that happens. Someone's diagnosed with a terminal illness. It is a fact that they are going to have emotions, and some of those are going to be very vulnerable emotions that people are worried about how they will be perceived when they have those emotions. And then we choose how we respond to that emotion. So I talked about that fight or flight response with the sympathetic nervous system. And I think we do that with emotions. So people can have emotional flight where they want to avoid that unpleasant sensation. And so we all know this, that this builds up into that total pain picture, that if someone is trying to push down that unpleasant sensation, it's going to take a lot of strength. So yes, they're being strong, but they're going to try to move past it and maybe use old forms of coping. So this is where chemical coping might come into play. And I think that that is the way that people have learned to get by with difficulty in their life. But I think there's another option. And I think that this is the path that most of us would choose, which is that emotional fight. So trying to face that truth, trying to face that discomfort. And we talk in palliative care about both and, right? That you can do both things. You can be afraid and be courageous. And all this palliadelic stuff that's coming out about trying to go in and through, go into that hard space to get through it and get on the other side of it. And if we are able to do that, then that's where we have the ability to have transformation and further ways of connecting that we weren't aware of before we had this illness. So in my mind, the reality of what we should be trying to advocate for is that courage equals being emotionally strong. And that means braving the unknown, going into these places that we haven't before with the support of people who can hold that pain with us. And then fear and vulnerability is just a fact of life. So this is the full poem that again, I'm not going to read through in the interest of time, but to show that appreciation for strength is something that is vital, that we need to survive. I love that last line, but courage is what helps us to fully thrive and live and feel all the spectrum of emotions and experiences of being human. So if you hadn't gotten a vibe, I listen to a lot of Brene Brown and I have all of her books on my nightstand. I love her quote so much. You can choose courage or you can choose comfort. You cannot choose both. I will say that this resonates for me as a palliative care clinician, that when I'm going into rooms, there are some times where I am not comfortable having the conversation and I avoid it and I kick the bucket down the road for another day. And so I think that if a lot of this feels new, or excuse me, if a lot of this feels old for patients, I would ask you, like, if this resonates for you as a provider in terms of these emotions that we bring to it. So I want to spend this last bit of time talking about how we respond to emotions and how we can continue to evolve this over time. So we have the Vital Talk framework for nurse. I use this all the time. It is huge. It is 80% of what I do in my outpatient practice. And at the same time, I think that we also talk about this, you got to meet them where they are, right? I love this inspirational, aspirational quote of, but don't leave them where they're at, that we need to try to keep pushing as best as we can. We can't push past where they are, but the goal is to try to shift where they are in terms of their emotional experience. Dr. Lucas is a palliative medicine at the VA here in Omaha, and she has this framework that I love. And her first piece, that making friends, I have to build trust with my patients. If they do not trust me, the rest of the conversation is going to be extremely difficult to get through, if I can get through it at all. And there's this podcast that I highly recommend if you have not heard it. It's the Jerry Powell podcast that was in April with Dr. Chalmers and Dr. Brenner, who are psychiatrists that are in palliative medicine. And they talk about this, this therapeutic presence, which is what I want to end on, of what is really important about what we do. So they have three aspects to this therapeutic presence. And I think most of us can recognize what that terminology is, that this is the stuff that we don't feel like we're doing a lot. We walk out of a room, we say, I don't know if I did anything, but we did a lot of groundwork that's difficult to perhaps quantify. So they talk about three aspects of this therapeutic presence: a deeply attentive presence, naming the core experience, and creating a holding space. I think all of us probably inherently do this deeply attentive presence. These are the things that we generally think about as important to our practice. That naming the core experience goes slightly beyond that naming skill in Vital Talk. So that's the real naming. So putting into words that dread that patients and families have, actually getting the D word out there, the death and dying, and actually addressing the grief. So when I have patients that say, I'm in the Midwest, right? We've got a lot of farmers that they're like, oh, I don't really like to think about myself. But this just sucks. And they're like, but I don't want to pity myself. And I'll say, what you are experiencing is not pity, it's grief. You're experiencing loss because things are not the same as they used to be. You're never going to be able to do the things that you used to before. And that needs to be acknowledged. So the example that they give in the podcast is you're sitting in a family meeting, you've got that really anxious family member who's asking tons of questions that don't relate to what you're trying to get to. And to be able to have the courage as a palliative medicine provider to put it out there, it's totally petrifying to think about what life is going to be like without your family member. And that's those moments where you can feel the shift in the room, where the mood has changed and kind of that tension has gone down a little bit as well. So that idea of the holding space, I just put a lot of quotes because I just think that Dr. Brenner put it so perfectly, that we can hold that pain with people, that people can express this emotion and we are not going to run away. We're not going to move on to a new topic. We're not going to falsely reassure them. We're going to sit there with them and hold that pain with them and tell them that you're not going to fall apart. You can get through this. And I think particularly in the context of trauma, that's really important, our ability to hold that pain for people. So Dr. Brenner talks about, it's about connection, not perfection. So as much as I want to try to get all of my patients to hospice, sometimes I just can't get them there, but I would rather maintain my emotional connection with them than try to push hospice and have them say, I don't want to talk to you anymore, that I can only go at that pace, but still try to push as best as I can on those emotions. So this is just my framework, just trying to emphasize these final things about, showing that curiosity, being able to name the emotion, but then go deeper to that core experience to acknowledge and validate that, and trying to find new ways for coping and connecting. So that is my presentation.
Wonderful. Thank you so much, Mel. And as you can probably see in the comments, other people are thanking you too. Does anyone have any questions for Mel, or were there points in this presentation that really touched on your own experience as a palliative care provider?
Mel, my name is Chaplain Ruth, and I really appreciate your presentation, and obviously it's very connected to what we do as well. And but I got a little anxious when you said that we meet them and then we push them. Yet then when you went further and talked about the 3 aspects of naming the core emotion, being deeply attentive, and creating and holding space, I think it's in that the movement then happens. So it's not necessarily that we're pushing them.
Yeah.
We're receiving them and holding the space that allows them to move. So thank you.
Wendy, yeah, I can send my slides to Marty and have him distribute them with the group.
Sure, yeah, I'd be happy to.
Thank you. I just wanted to add in, that was just such a lovely presentation, the way that you had it flow with very, complex things sort of made simple. I just think it was fantastic. Thank you.
Mel, you talked a lot about how our bodies hold the emotions and express them even when our words don't, and how you've been more conscious about that in your own practice. Can you tell us a little bit about the techniques that you use to try to manage the emotions going through your body when you enter these conversations?
Yeah, I do not pretend to be an expert in this. This is a lot of the work that I'm doing is kind of my own practice improvement. We're working with an integrative medicine group for our fellowship about trying to have more. I will say, I think we are, maybe I don't know if you all feel this or not. I am so in my head that I forget what my body is doing. And with a little bit more confidence, I think that has kind of taken care of my body. But especially when I'm feeling this external pressure of this patient's not ready to talk about hospice, but I have to talk about hospice, or I have to talk about the fact that they're dying, but they're not there yet. And so there's that anxiety. And so I think it manifests with how long we stay in the room. I think it manifests with if the patient's not ready to talk, I say, are you ready to talk about this? And they say, nope, don't want to talk about it. And then I look over at the other family member. What are your thoughts? I support them. And so then the conversation's kind of done, right? Like I don't necessarily have anything else that I can say to them. And so I think what I more typically see is that as the palliative care clinician, then I might be like, okay, I'm going to leave the room. And then gradually what we tend to do is we come back to that room less and less, the more resistant those families are, when I would argue that those are the families that need us the most. And it feels awkward and strange to keep coming back and to have, I think as a physician, it feels very awkward to have a completely non-medical conversation, especially in the inpatient palliative medicine setting. But I would argue that that's where that trust building has to happen. And so I think that's where it's shown up for me more, is that there have been times where I've said, I'm too scared to go back in this room because I'm worried that they don't like what I have to say. And so it's that I start to pull away and not come back as often, and then maybe kind of even sign off on those harder patients when they're probably the ones that need us more than anyone else.
Hey, Mel, I had a question about
Yeah, I'm trying to follow the chat.
about one of the themes. So I took some notes, and there was a commonality here about going in, but not just going in and staying there, but going through and not leaving them where they're at. And I think back to when I was a fellow and some of the potential harm we can do taking people into that place, but then not talking about how do we get out, and sort of leaving them in despair, sort of picking at that scab, but then not having an exit plan. And I worry, I think that's such an important piece to finishing off the other half.
Yeah, and this is where I'm reading a lot more about trauma, and because I think particularly people who have those highly sensitized reactions to things that are triggering for them, is I think those are the places where we actually can create iatrogenic harm with what we are trying to do with best of intentions in palliative medicine. And so I think that being aware of trying to get a sense of how that person is emotionally responding, and if it seems like they're actually having more of that kind of triggered reaction, how to try to handle that. And so I think it's those, this is kind of getting back to your question, Kristen. I think it's that calm body, that being able to physically embrace people if they will let us do that there's actually neuroscience behind being able to hold a hand or to give a hug is actually kind of calming down that high nervous system reactivity. And I think that holding space is that a lot of us, at least early in my training, I didn't know what to do with that, but being able to sit there, and the biggest thing that I've learned is just saying thank you. Thank you for sharing that with me. I really appreciate you showing me that, and I'm so grateful for you. And you're such a lovely, wonderful person. That has tended to be the way that I can kind of come back to the present. And then we've shared that experience together. Sorry, my lights turn off. But having that shared experience actually builds the trust too.
Thank you, Mel. Any other questions for Mel?
Yeah, I just want to, oh, sorry.
Yeah, no.
Rachel, talking about the body scan. So one of the things that I'm starting to get into with more trauma-informed care is this therapeutic framework of within the field of psychology called internal family systems. And it's very heavily related to what they're feeling in their body and trying to kind of do that body scan, and then focusing on that part as an intro to trying to get to some prior traumas that are triggering that these emotions are connecting with. It's a very complicated thing, but Ruth is shaking her head, so she can tell you more about it.
Great, thank you.
Oh yeah.
Did you see Wendy's last question?
Yeah, so I would argue that I'm also doing that over video a lot of the time. So there's even an extra distance that I'm in a room with other people, so I've got the mask. I have become the biggest caricature of myself ever. So I'm going, yes, and if someone says something funny, I'm buckling over before, whereas they can't see that facial expression. And I'm very loud. So I think I try to still keep that calm tone of voice, but I project a lot more than I used to. So I think I still do the same things, but I just doing that in an amplified manner so that people can really see that.
All right. Thank you, Mel. That was wonderful. We really appreciate you. We'll have to have you on very soon again.
Once I'm an expert in trauma, I can come back.
All right, everybody. Have a wonderful weekend.
Thank you.
See y'all next Friday.